Hi, hello, good evening, everyone. I'm Vincent Huberty from Erasmus Hospital in Brussels, and we welcome you to the ESGE webinar. It will be about bariatric metabolic endoscopy, new devices and new indications. We have two outstanding presenters, Jan Kral from Czech Republic, as well as Professor Barham Dayyeh from the Mayo Clinic. While Jan will speak about bariatric gastric EBMT, Barham will speak about small bowel EBMT, and I will go through both presentation and we'll have some chance to have some discussion afterwards. So please do not hesitate to ask questions through the Q&A. While we start with the presentation from Jan Kral, who will speak about gastric EBMT. Jan, the floor is yours.
Hello, everyone. Thank you very much, Vincent. First of all, I would like to thank ESG for the opportunity to be here with such expert like Vincent and Barham and to give you a short talk about space-occupying devices and endoscopic sleeve gastroplasty. Everybody knows what obesity is an abnormal accumulation of fat which leads to health consequences. And at the end, it will definitely decrease the quality of life of your patients. It's defined as a BMI of more than 30 kilograms per square meter. And we need to keep in mind that obesity is a chronic disease like arterial hypertension or type 2 diabetes. And it's connected to many complications such as cardiovascular diseases, metabolic associated fatty liver disease, cancer, type 2 diabetes, depression, and all those are arguments why we should focus on patients with obesity. And we also know that prevalence and incidence of obesity is rising and predictions are not really looking good. For example, in 2030, there will be more than 50% of US population obese, not just overweight, but obese, which is very alarming. And Europe is following this trend as well. But what is even maybe more alarming is that children are keeping pace with adults. And for example, after COVID-19 in Czech Republic, children obesity tripled. So this is another argument why we should focus on obesity as itself. And this comes together also with costs, and I mean direct costs, but also indirect costs. For example, nowadays, cost for treatment obesity and its complication rises in European Union for more than 70 billion euros and in US $870 billion. And as you can see here in our predictions by 2060, the cost in US will be 4 times higher. And in Asia, I can't even say that number, right? So this is things why we should keep an eye on. What are treatment targets? We usually focus on 2 parameters, total body weight loss and excessive weight loss. And recently, there were published new guidelines by ESGE and ESGE, and we would like to have our endoscopic procedure efficacy at least for 5% of total body weight loss. And why 5%? The answer is pretty much clear. If you reduce your weight for at least 5%, you will reduce the risk of cardiovascular diseases. If you can be able to reduce 7 or 10%, you will be able to reduce the risk of type 2 diabetes and its complications. And honestly, we can do way better than just 5%. What is the indication for endoscopic bariatric procedure? It's a BMI 27 to 29.9 with at least one obesity-related comorbidity, or BMI more than 30 with or without obesity-related comorbidity according to new guidelines. But we need to keep in mind that we do not have really many guidelines on endoscopic bariatric procedure, and recent guidelines, they have usually moderate to low recommendations. So we need to work on that, have more data to have our recommendation more stronger. Let's have a look on space-occupying systems. These are generally intragastric balloon systems. So the intragastric balloon will occupy the space in stomach, which will lead to early satiety of our patients. It will also delay gastric emptying, which is very important. And those intragastric balloons can be placed for 6 or 12 months. Usually they are placed during endoscopic procedure or as a swallowable capsule, and they are usually filled with solution or air. The average volume is at least 400 milliliters, but we usually at 500-600. This is Professor Maselli from Italy. She's placing Orbera 365 during endoscopic procedure. Now you can see here Orbera 365, and she will connect the syringe and she will start filling the intragastric balloon, and you will see how slowly the balloon develop, and when she will fill like 500-600 milliliters, then she will just pull out the filling tube, and there's a valve which will close, and the procedure is done. Then she needs to get back in this particle balloon after 12 months and take the balloon out. Now she will start filling the balloon, and you will see how slowly it develops. Generally, the whole procedure takes not more than 15 minutes to be done. There are many manufacturers and many types of intragastric balloons. Let's say the classical ones like Orbera, Metzel, Conavita. Then we can have a Spatz, which is a special one, which can be adjusted in upwards and downwards meaning. So you will pull this small filling tube up, and you can add another 100 or 200 milliliters. Then there are swallowable systems like Ellipse. So you will swallow a small capsule, and which is filled by this tiny tube. Then you have all balloon balloon system, also swallowable system. These three intragastric balloons are filled with air, which are placed in a sequence, and three-shape duo, which is double balloon system. And it's just up to you which kind of balloon you will prefer. What are contraindications for placement in intragastric balloon? It's ulcers, anticoagulation therapy, gastric surgery, severe liver disease, big hiatal hernia, pregnancy, or active IBD in a mean of active Crohn's disease in upper GI. What is not clear contraindication is LIA and B esophagitis, gastritis, hyperplastic or benign polyps, HP positive. They probably antiplatelet their therapy. So there is no clear consensus on many questions what is and what is not contraindication. So probably the best source what you can find out now is Brazilian intragastric balloon consensus from 2018. How about adverse events and complication? We need to educate our patients that they will certainly have some adverse event. They will experience side effects like vomiting, nausea, abdominal pain, discomfort. It's very common, but it doesn't last very long. Usually after 5 days, patient will get used to intragastric balloon and they will do fine. Complications such as balloon deflation, gastric perforation, aspiration, and many others are severe complications, and they are common less than in 1%. But mostly you will experience dehydration. But also you need to educate patient on that as well. Before you are going to place intragastric balloon, all patients should be examined. So generally, if you're doing bariatric endoscopic procedures, you should have established multidisciplinary team, which is a gold standard. So there should be their diabetologists or endocrinologists, GIs, surgeons, nutritionalists, physiotherapists, and many others to go through all your patients and indication. Before you're going to place the intragastric balloon, we recommend patients to start taking proton pump inhibitors, and they are administered with antiemetics as well, and they follow just liquid diet for at least 24 hours before the procedure. After the implantation, patients continue with proton pump inhibitors and antiemetics for 3 to 5 days, which will help them to lower possibility of side effects, or those side effects will be mild for them. Also, diet will help us patients to get used to those intragastric balloons, like clear liquids for 1 to 3 days, then full liquid diet like protein shakes, then pure and soft food. And after implantation, it doesn't end. Patients should be followed up by nutritionalists. I usually see patients after months, and then every 2-3 months. And they're also advised to start exercising, usually after 3-4 weeks. When they get used to those intragastric balloons, they are pretty okay to start workout. Before the explantation, we recommend patients to keep liquid diet for 48 hours. The question is why? It's pretty much simple, because at the beginning I said that intragastric balloon may delay gastric emptying. So when you go in and there's a food which you can't suck, it's been very difficult to take the intragastric balloon out, and you may experience some severe adverse events such as vomiting and aspiration. So do not do that. Just quit the procedure and reschedule your patient for another date. Let's have a look on some data on intragastric balloons. We've got plenty of publications, a lot of studies on that. So I'll just pick one of the best. This is from my colleague Barham Dayyeh, 288 patient intragastric balloons which were adjustable against control. And as you can see, after 8 months, patients were able to lose 15% of total body weight loss against just control. And you can see they adjusted those intragastric balloons for another 150-200 milliliters, and they were able to increase their total body weight loss for another 3%. Also, those patients experienced some side effects like nausea, dyspepsia, which are very common, and they were okay after a few days. This is experience from Spain. More than 20,000 intragastric balloons, 12 models, and mean total body weight loss was 17.6%. And what is even more important is that major complication was just 0.7. So severe adverse events are very low in intragastric balloons. Adverse events 6.3%. Well, that's this for discussion, right? I would say this number should be a little bit higher, but the most important is severe adverse event. So generally, we can say that intragastric balloons are effective way how to lose weight. It's safe, and it's also cost effective if you compare it to GLP-1s or just lifestyle modification. I will just briefly touch transpyloric shuttle. It's a device made for two balloon. One is in stomach, second one is in duodenum. It's dealing gastric emptying, and there was one study from Shelby Sullivan, total body weight loss 14.5%. There were some side effects, so now there's a new development of new transpyloric shuttle, so we are keen to see a new data on this interesting device. Let's jump on endoscopic gastric remodeling. This is a, let's say, brand new name for endoscopic sleeve gastroplasty. And we can do this gastric remodeling using 3 different devices. First is overstitch endoscopic suturing system from Boston Scientific. They've got 3 versions, Gen 2, ESGE, and now there's coming NXT. Then you can use incision operation platform from USGI Medical for post procedure, or Endomina system from Endotools Therapeutic. I will touch all those devices. How endoscopic gastric remodeling works? Actually, it will reduce the volume of stomach, which will lead to lower caloric intake by your patient. Also, it will delay gastric emptying by just temporarily for a few weeks. And there also might be some changes in hormones such as ghrelin and YY peptide, but definitely we need more data on that. What is contraindication for gastric remodeling? It's gastric ulcer, congestive gastropathy, gastric polyposis, esophageal varices, or untreated psychological disorder. What is not clear contraindication, or there's no clear consensus from experts, it's mild to moderate gastritis, hyperplastic benign polyps, HP positivity, or previous gastric surgery. If you want to see some more data on that, definitely Brazilian consensus on endoscopic sleeve gastroplasty would be one of the best sources to go. What adverse events your patient might experience is vomiting, nausea, GERD, nutritional deficiencies, which are not as common as in bariatric surgery procedures or abdominal pain. So you need to, again, educate your patient about those. And there might be also severe complications such as perforation, severe bleeding, infection, but those are common in just 2%, not more. So it's very safe. Gastric remodeling is done under general anesthesia with CO2 insufflation. Patients are administered with analgesics, especially after the procedure. Don't be worried to use also opioids because make your patients comfort. And we recommend to administer antibiotics as well. We usually go for ciprofloxacin and metronidazole before the procedure and one dose even after the procedure as well. After the procedure, patients continue with proton pump inhibitors up to 3 months, antiemetics for 3 to 5 days, just to lower the side effects, possible side effects, especially vomiting, because when patients start vomit, they can disrupt the stitches. So try to keep them on those antiemetics. Also, diet will help us as well. This is pretty much the same as after intragastric balloon. So clear liquids up to 3 days, then full liquid diet. And we try to keep them on full liquid diet for more 2 to 3 weeks to get all those stitches healed. And of course, those patients needs to be followed up by you, nutritionists, psychologists, and they can start exercise. We usually recommend them start exercising after 6 to 8 weeks after the procedure. Let's touch all those devices. This is ESG using Overstage from Boston Scientific. You usually start in antrum like 5 to 6 centimeters from pylorus, and the gold standard is to have a full thickness bite. So when you close Apollo, you feel a small click, which means that you are full thickness through the serosa. What kind of suture you use, it doesn't really matter, and I'll tell you later. Let's have a look on some data. This is results from MERIT trial from our colleague Barham, 209 patients, ESG plus lifestyle modification, again, just lifestyle. And you can see after 52 weeks, they were able to reduce their weight from 13.6% against control. And those who were in control crossed over to ESG. They were doing pretty much the same as a primary ESG. So very impressive results, and severe adverse events were reported just in 2%. This is something pretty much new. We do not have many data on that right now. There was just small trial by Chris Thompson. This is endoscopic sleeve gastroplasty plus myotomy. So what you basically do is that you start with pylorus sparing myotomy. So you will cut the antral muscle, which will cause gastric delay, and then you will perform endoscopic gastroplasty. And as you can see, those 6 patients were able to lose 14.8%, and gastric time delay was significantly longer, so from 6 to 8 to 204 minutes. So when I was talking with Chris about this procedure, he probably would start just with myotomy first, and after a few months, if patients do not lose weight, he will add this ESG too. So it's very impressive way how to lose weight. Now, just slowly to suture patterns. As I said at the beginning, there's no real difference what kind of suture pattern you use, right? There is a significant difference in excessive weight loss, but if you look at the total body weight loss, there was no significant difference, and same with the number of sutures. So it probably doesn't play a role what suture pattern you will use. Let's move to primary obesity surgery. Endoluminal pose procedure. You can have 2 types of poses, traditional or distal pose. These are data from traditional pose from Lopez. Now, 147 patients, and after 12 months, they were able to lose 15.1% of total body weight loss. So there's a question why we should start doing distal pose, and I'll tell you right now. This is a study from Gerapino. They compared single versus double helix distal pose. So double helix, 2 gastric folds, single helix, just 1 gastric fold, and you can see a significant difference between those. So double helix patients were able to lose 20.3% total body weight loss, again, just 13.4%. So very impressive results. And let's have a look on last device. This is Endomina. It's pretty much a new kind of device for ESGE. So you place endoscope through those two branches. You grab the gastric tissue, place a first tag, then you go to other side and place a second tag. Then you open the device, take out the endoscope, grab a snare, and try to catch a small ball. And when you catch it, you start tightening up slowly and gently the stitch, and you will reduce the volume of stomach. Then you place another stage and another, and you will finish the procedure. In my point of view, the learning curve is a little bit faster than in a post or overstage. So very impressive device. So let's have a look on some data. This is one of the first studies which were published, 48 patients. Total body weight loss was 10.11%, no severe adverse events. And as you can see again, they tried different suture patterns and there was no clear difference between those. And another study with Endomina published by our moderator in GAT, Vincent Huberty, 71 patients, and they were able to, at 6 months, to lose 38.6 excessive weight loss. And after 12 months, even more, 45, very nice. And the mean of total body weight loss, it was around 11.8% and no adverse events. So very, very nice data from Vincent. So in summary, we can say that endoscopic gastric remodeling, if you use overstage or Endomina post, it's very safe. It's very safe. It's minimally invasive. Patients has fast recovery. They usually don't have to be admitted at hospital, so they can go home after a few hours. And we've got even some long-term data. Rimsha published 5 years of endoscopic sleeve gastroplasty, and as you can see, it's 15.9%, so very nice data in long term. And also, if you look at studies of cost effectiveness, it's a cost effective in a compared to GLP-1s or even intragastric balloons. At the end, I would like to show you a brand new device. It's not CE mark yet. It's a fully automated system for gastroplasty called Endoscopic. I will jump on video right now. It's better. As you can see, it's pretty much a big device through which you will place nasal endoscope right here. And to these chambers, you will suck using vacuum pump. You will suck the gastric tissue, and then you will start suturing. And so first you place over tube, then you place slowly the whole device, and you're trying to find the right spot. As I said, 5-6 centimeters from pylorus in antrum. You can use those levers to find the right spot. When you find it, you just take out the nasal endoscope. So the suturing is a bit of blind procedure, right? And you place a special plug and you close suction and you open vacuum pump. And in that time, the gastric tissue is sucked into the device and you just press a button. It will start suturing in a circle way. Then it will start tightening up the suture, and finally it will place a cinch and cut the wire, and the procedure is done. I mean, the first stitch is done. You take out the whole device and you place another one. So you repeat those steps 4 or 5 times and you got your procedure done. Let's have a look on how it looks after right after the procedure, and you will see that this was pylorus. And you see that the reduction of volume is pretty much impressive in my point of view, and very nice. And now you'll see how it looks after 3 months. And it seems that the reduction is still there, quite okay in my point of view. You will see some cinches over here as well. So let's have a look on some unpublished data yet. We performed 45 patients in 3 centers, and you can see after 12 months, total body weight loss was 30.2%. So very nice. And what is even better, that the whole procedure can be done in 30 minutes. It's very fast, and same the learning curve of this device is very fast. Severe adverse events were reported in 2%, and it was gastric perforation. So if you are interested in bariatric endoscopy, you definitely should go to ESGE statement position statement, which you will find what you need to do, what you need to know, how many procedures you should do to become competent in bariatric endoscopy. Thank you very much for your attention.
So thank you very much, Jan. It was outstanding presentation with a full view of all the devices. There are some questions that pops up into the Q&A, and I'm super happy about it. But we'll now move to the presentation of Barham, and at the end we'll talk all together and try to reply to all those questions. So let me introduce our next speaker. We have the chance and the honor to have Barham with us tonight. He is a full professor at the Mayo Clinic, and he will speak about the small bowel EBMT. Barham, it's on you.
Thank you, Vince, for the kind invitation, and it's an honor to be with you all talking about small bowel interventions for obesity and metabolic diseases. These are my disclosures for the purposes of this talk. The premise of this talk, which is an important paradigm shift in our field, is that our hope for a treatment that could modify metabolic disease, not manage here, that could modify metabolic disease, is targeting the small intestines, because the answer for the solution for type 2 diabetes and diseases like metabolic liver disease lies within the gut. That means the gut offers the best hope to modify the pathophysiology of the disease, not merely managing its symptoms, and therefore the gut and the small intestines are a very important therapeutic target for management of type 2 diabetes and metabolic liver diseases. And that's becoming a clear paradigm. And you could ask yourself, why is that the case? And I will give you the analogy of a symphony orchestra. And imagine type 2 diabetes being a dysfunctional orchestra. And the dysfunctional orchestra cannot mount a response to the ingested meal in order to regulate blood glucose. And now our management strategy is to improve the orchestra function. We focus on its individual players. So if the flute player is not playing well, equate that to insulin resistance. We replace the flute player with a bunch of medication that works on insulin sensitization. If the violin player stopped working well, equate that to beta cell insufficiency. We give a bunch of things that would improve beta cell function to release more insulin, and more so, we give insulin itself. So in that paradigm, we're just focusing on management of downstream dysfunction. We're not focusing on putting that orchestra back in sync. So the paradigm here with the gut, instead of focusing on downstream signals, we could go back to the orchestra conductor themselves and allow them to make that orchestra in sync. And that's the premise of using the gut as a therapeutic intent for metabolic diseases. And if you want empiric evidence to suggest or to show that the gut is the orchestra conductor, I refer you to some of these reviews, but this is in essence the integrative function of the gut. And you could see that at the center is the small intestine organizing the metabolic response via communicating the signaling to downstream organs like the pancreas, liver, and muscle. And if we want to measure dysfunction of that orchestra and dysfunction of the gut in organizing that orchestra, you could measure what we call the incretin response. This is a nice review published in the Lancet, or nice paper, sorry, published in the Lancet Diabetes that measure the ability of the gut to orchestrate or to conduct that orchestra. And the measurement is with the incretin response. And the incretin response, simply stated, is the ability of the gut to mount a response to an ingested load of glucose. And you could see that this is indicated in the graph in gray. And in a normal healthy individual, that is the ability of the gut to mount a response to an ingested load of glucose. And in states of type 2 diabetes, you could see it in red, that ability of the gut to do the same is severely diminished. So that means that the gut stopped conducting that orchestra. And right now, we do not have a treatment that would recapture that effect. And therefore, having the gut as a therapeutic organ in the treatment of type 2 diabetes is not only a strategy to manage the disease, but potentially to modify its outcomes and to decrease its burden on the patient. Now, there is a significant interest in using gut-based therapies like the GLP-1 agonists or GIP in order to treat pharmacologically type 2 diabetes. And these drugs are important addition with a lot to celebrate. But it's important to highlight that in states of obesity and metabolic disease, there is no deficiency in these hormones. Just like insulin resistance, there's actually resistance to these hormones. And therefore, it's important to target that resistance to these drugs as a disease-modifying target for metabolic disease. And that's where the gut becomes important, because that resistance originates from the gastrointestinal tract, because that's where these hormones are being produced. Now, we in endoscopy have the best access to diagnose and to treat these proximal small intestines because we have access to upper endoscopy. And if you place your scope in the duodenum, which is a maneuver that we all do thousands of times daily, you could see that if you magnify the gut lining, you could see how rich of an ecosystem. It looks like a chemistry factory, that it integrates signals from the food that we eat, from the microbiome, and it tastes what's going on in the lumen and have to orchestrate that metabolic response to key metabolic organs. Now, again, the duodenum is the central orchestra conductor because it's integrating signals from the nutrients that we eat, from the gut enteric nervous system and the gut immune system, from the microbiome, and from the gut hormones in order to communicate these signals through the projections, the crypts and villus that I showed you, to the submucosal nerve plexus, what we refer to as the second brain. Is that rich of a plexus. And that in turn communicates it to key metabolic organs, such as the pancreas, liver, and muscle. Therefore, similar to the analogy of the orchestra, resetting that signaling is an important disease-modifying or potentially disease-modifying treatment approach for type 2 diabetes. And I showed you the cartoon, but actually this is real life. We're in the duodenum. This is underwater immersion. We're using near narrowband imaging, and we're using the near focus function on the modern gastroscope. And you could see the rich ecosystem of the duodenum with, it looks like the coral reef with these crypts and villus communicating or sensing and communicating signaling for the metabolic response. Now, again, if we target the duodenum with a biopsy, and we expose the submucosal plane as shown here. And here's the submucosal plane, and you put confocal microscopy, for example, you could see the enteric nervous system. And it really looks like the central nervous system with multiple nerve projections communicating this metabolic signaling to key metabolic organs. In states of type 2 diabetes, the system becomes inertia, or the orchestra conductor stopped conducting, And our task is to try to regenerate that response using the gut in order to treat and modify course of metabolic diseases such as type 2 diabetes. Now, what happens to that duodenum in states of metabolic disease? And the literature is quite clear that what happens is in individuals with susceptible genetic background exposed to the Western style diet, there's a state of low-grade inflammation. There is dysbiosis that happens. The gut permeability becomes impaired. You have increased translocation of both fatty acids and mediators of inflammation. And this is resulting in a state of dysbiosis and inflammation that causes fibrosis in the gut. And this is a core principle of why the gut stops functioning well and we lose that incretin response in states of type 2 diabetes. And again, the inflammation that originates in the gut will communicate to key metabolic organs. So the inflamed gut will result in an inflamed liver, will result in an inflamed pancreas, inflamed adipose tissue, and inflamed muscle. And now you have systemic inflammation with its negative consequences on health and metabolic diseases as well. And this is the interesting story that highlights the important role of inflammation in metabolic diseases. What you could see on the x-axis is BMI. This is published in Science, by the way. And on the y-axis is the change in the inflammatory milieu with metabolic disease. And to just simplify that graph, what we're having is we're having a switch from immune tolerance to pro-inflammatory, from predominance of Treg cells to predominance of pro-mediators of inflammation, such as neutrophil. So we have clear state of chronic inflammation that is associated with metabolic diseases, and that state likely originates from the gut. And that inflammation is also communicated with, again, as I showed you, with key metabolic organs, such as the beta cells of the pancreas. And you could see the changes in the inflammatory milieu in the beta cells, resulting in inflammation and fibrosis. And that is a key culprit in the insulin insufficiency that we see with type 2 diabetes as well. Now, if we look and we started forming that term, diabetic duodenopathy, and you would see it, and now we're using AI to help us define that term further. But to put it simplistically, in the figures on top, this is the crypt and villus in the duodenum using endoscopy and narrowband imaging in a state of metabolic health. You could see that these crypts and villus are regular in size. They're uniform in shape. They look that their core is not expanded, and they have a halo around them without much chyle or fat deposits. Now compare and contrast the image from somebody with advanced type 2 diabetes. You could see a completely different picture. The crypts and villus are in disarray. They're disorganized. If you look at their core, you're having an expanded core with increased neurovascularization and inflammation. The core is getting red, and there's increased capillary expansion. The halo is also diminished, so you have attenuated halo, and you could see there's increased chyle and fat deposits within that duodenum. So the question is, knowing what we know about the central role of the proximal gut in metabolic diseases, could we now use endoscopy as an access tool in order to reverse that metabolic clock? Because endoscopy have the advantage of being organ sparing. It has the added safety and efficacy of anatomy preservation with little or less long-term consequences on health. And it maximizes compliance of the patient because it does not require an injectables every week. And if we could leverage the gut, we could modify or decrease the burden of drug therapy. So John talked to you a lot about the gastric procedures. I'm not going to belabor these. And the gastric procedures work mostly to improve metabolic diseases through weight loss pathways. That means you lose weight, you get improvement in your insulin resistance, and with that comes improvement in type 2 diabetes. So the gastric devices result in metabolic improvement through weight loss dependent pathways. The small intestines, on the other hand, have an added benefit in that they work on weight loss independent pathways. Now, there's some weight loss dependent or some weight loss that you observe with these interventions, but most of their function comes by changing insulin resistance, bile and fat acid signaling, inflammation, which is a key change that we see with these interventions, and the incretin and the microbiome as well. So they have a significant proportion or significant advantage in modifying the pathophysiology of metabolic disease. So the question here is, are we embarking in an era where we could use upper endoscopy to regenerate these abnormal signals from the proximal small intestines in order to treat metabolic diseases such as type 2 diabetes and decrease its burden? That means instead of adding and progressing to insulin, decrease in its burden by reducing the number of required medications and eliminating the need of insulin over time. And that is the hope of regenerative small bowel intervention for the treatment of type 2 diabetes. And we have multiple modalities that are trying to target the intestines as a regenerative modality for type 2 diabetes. I will talk about a few. This is a technology that is based on Mayo Clinic intellectual property, licensed to a company called Endogenics. And with this modality, we use pulse electrical field. So this is non-heat. There's no temperature rise. This is athermal regeneration. These are short waves or short pulses of pulse electrical field that introduced through this catheter for nanoseconds. And what this allows is athermal regeneration of any cell with a phospholipid membrane without affecting the extracellular matrix, the blood vessels, or the lymphatics. That means you do not need to lift in order to administer this therapy because there's no heat being generated. And you could go deeper to the submucosa for regeneration of potentially regenerating nerves with this technology because of its athermal nature. Now you can see how would electroporation look. This is a new way that we could regenerate things in the GI tract. This is the duodenum before treatment. You could see that's the narrowband imaging corresponding to these diabetic duodenopathy changes I've been talking to you about. This is immediately after you administered pulse electrical field. You could see here is the untreated area in pink. This is the circumferential blanching immediately after administering the pulse electrical field. And because there is no heat, you wait for about an hour and things turn back to pink with very minimal coagulative necrosis effect. And you could see that image correspond to the 1 hour here. This is again the untreated area versus the treated area. You could see that after 1 hour, we have treated the mucosa, but also exposed and treated the submucosa as well, as if you're removing an old carpet and replacing a new one. And in 4 weeks, that area regenerated with hopefully healthy mucosa and submucosa to recapture the metabolic effect as shown. Again, this is data from 71 patients across 3 continents, showing that with more electricity, so low dose, mid dose, high dose, you have a dose response in the effect on type 2 diabetes, reaching in patients who are failing multiple drug therapy, reaching an A1C improvement of more than 1.5 A1C at about 48 weeks as presented. Now, there's other modalities to regenerate the duodenum, and this is from Fractal. This is based on hydrothermal. With this technology, you're using heated water in order to ablate the mucosa. So you are actually requiring a submucosal lift in order to isolate the submucosa from damage because of the heat-based modality. But again, this treatment targeting the gut showing also great promise, and this is published in Gut, showing a significant improvement of hemoglobin A1C at the 12-month mark when we target the gut with these regenerative interventions. Now, along the theme of regeneration, we're going to see an era where we would likely use endoscopic ultrasound in order to introduce a viral vector. Again, this is coming from Fractal, where you use EUS guidance in order to inject a viral vector and allow the pancreas to start producing a GLP-1 agonist in response to a nutrient load. Definitely interesting area, still early on in early animal feasibilities, more to come on these interventions. Now, in the last few minutes, I would like to give you a glimpse about the future and what we should look for in the next 5 years. And we should be looking for endoscopic surgery, where we could now push the efficacy to similar to bariatric surgery, but in an endoscopic approach that has advantages of being less invasive with a more favorable side effect profile. And there's multiple technologies trying to target this. This is a combination of intragastric balloon and intestinal liner that is designed to kind of replicate the physiology of a raw gastric bypass. And now what we've learned from advancement in bariatric surgery, that this operation, which is the single anastomosis gastrointestinal bypass, has a very strong metabolic benefit. And with this operation is you're having one connection between the stomach and the small intestines, and you're creating a volume restriction in the stomach. So you're bypassing the proximal intestines, creating volume restriction of the stomach through one connection between the stomach and the jejunum. So with that, it opens the era of using endoscopy to recreate this procedure without losing the anatomy. And this is from the group of Marc Barthé and colleagues who looked at using a NOTES approach to create a similar component of this procedure. Again, with NOTES, they exit the stomach, they find the loop of jejunum, they connect it with an axial stent to the stomach, and then they block the exit of the stomach with an occluder as a surgical endoscopic approach for treat for type 2 diabetes. We've been working on something a bit different in collaboration with Boston Scientific, where we create a gastroduodenal anastomosis, whether laparoscopically or by EUS. And as you would be pulling a PEG tube, you could pull this device that does not require any anchoring, because this device is based on a suspension of springs, and that will allow it to float in the GI tract without needing anchoring, and it will bypass the distal stomach and the intestines, creating an anatomy similar to single anastomosis gastrointestinal bypass. So again, once you create a gastroduodenal anastomosis, whether laparoscopically or whether with EUS, and you know how to push-pull like a PEG tube, you could just easily push that device in place with no need for fluoroscopy. Once you're at place, you release the gastric bypass component, which you would see this nitinol frame that is being released. And then you simply pull that device in place by pulling on the wires. Again, this is all under visualization, leveraging techniques that we're all familiar with, which is push-pull technique of pulling a PEG tube, for example. Once the device articulates the area that is to be finally released, you use an endoscopic scissors to release the articulating end at the gastroduodenal anastomosis. And now you have a gastrointestinal bypass that does not require any anchoring because of the concept of dynamic equilibrium. So it moves with the GI tract based on these nitinol springs and suspension, and it fights itself back because it's anchored at 2 points without suturing or without any plication. And then you could also then introduce that device and and do a abbreviated endoscopic sleeve on the rest of the stomach in order to fully create a single anastomosis gastrointestinal bypass. So in conclusion, therapies targeting the gut for correcting metabolic maladaptation in type 2 diabetes represents a new frontier in the management of metabolic diseases. They have the potential for disease modification and decreasing the burden on patients. With that, I conclude. Thank you for your kind attention and looking forward to answering any questions.
Thank you so much, Barham. It was truly outstanding, and the way we are going is truly exciting, and I can wait to see what you're doing and what will be the next innovation in the field. So guys, I have a few questions for you from the Q&A. I think the first one, which is the obvious one, is regarding the GLP-1 analogs and the place of bariatric endoscopy with the wave of GLP-1 analogs. I don't know what your thoughts are about it. Well, I know your thought about it, but I want to hear it. Can you give us a comment about it?
Shall I start, Barham?
Please go ahead.
Well, as I said, the cost effectiveness of intragastric balloons and GLP-1s is in pro for intragastric balloon and same as ESG. And ESG can give us a long-term effectiveness. And what I see a space for GLP-1s in my point of view, for example, is because intragastric balloons is a, let's say, short-term weight loss, because we know that after 2 years, let's say 30% of those patients will keep the significant weight loss around 10%. And that's why after explantation of intragastric balloon, I usually put patients on GLP-1, just small dose, and they will sustain and keep a little bit losing the weight. So this is, in my point of view, for me, place for intragastric for GLP-1s, or otherwise, if patient has just overweight, because we should focus also on overweight, not just obesity, then there is a space for GLP-1s as well. But we need to keep in mind that patients should be applying those GLP-1s every day or every week for 2-3 years. It's very expensive as well in a cost effectiveness way.
So Barham, do you have something to add?
Absolutely. So first of all, I am a fan of advancement in pharmacotherapies for obesity. Definitely, we need more and more interventions to address this global impact of metabolic diseases, and they are definitely going to be an important players in that. But ultimately, when we talk about the whole picture, we have to keep 3 things in mind: access, value, and patient acceptance. That means access, we need to have more interventions, pharmacotherapies, endoscopic and surgical for the patients. So we need to enhance access. So we're not competing, we're complementing the spectrum of care. 2, value, and that's where it's going to start maturing, is if you have an endoscopic procedure that gives you the same weight loss in a 3-year horizon as an injectable drug, which is more cost effective? Is it the endoscopic procedure or the drug? And these relative cost effectiveness are going to start becoming a thing as we mature this field. And then the third is patient acceptance. Remember, is compliance with medication is problematic. And we have data to show that there's significant cessation of use of medications. And that's detrimental because the medications have a rebound. And if we start becoming prey again to this yo-yo weight loss, weight gain, this is problematic. So the question of the best treatment is the treatment that the patient gravitate to. So compliance is an important part. And with endoscopy, we have the advantage in that we do a procedure and we rely less on the compliance because the procedure is done for the next couple of years or after that procedure. So now you might need to revise that procedure in a few years, but the fact is that it's one-time outpatient procedure that minimize the burden of remembering or taking a medication. And that it's all relative. It's all about value at the end of the day. We're going to have room for all these interventions. And I am very excited about a future where we're using endoscopies and medication to even do better for patients. And we're embarking on that journey together, actually.
I agree with you. And I think in the near future, we'll have more tools for prediction and to select better our patients. The other thing is just food for thought, but I think with the wave of GLP-1 agonists that we have right now, we will have within a few years, because of adverse events or compliance to the treatment, a lot of patients with the weight regain. So those patients will seek for procedures like EBMT, and I think this is the goal for us, is to be able to treat all those patients, but there are more and more patients that might come to us. So another question is regarding to the prediction. Is it useful to do a breath test to test the gastric emptying before a balloon or doing a gastric remodeling? I know that, Barham, you've just published a paper with Acosta about prediction. Can you maybe take this question?
Yeah, absolutely. So the gastric remodeling techniques work on multiple pathways, including some delay in gastric emptying, but also on changes in accommodation of the stomach, and some even affect the gut duodenal interaction in that fashion. Now, the balloon seems to have a significant impact on gastric emptying. So it seems to have especially the fluid-filled balloons, to have a delay in gastric emptying. And with balloons, if you delay the gastric emptying too much, you have the risk of intolerance and early removal of the device, and more so if the patient is not being followed carefully with their team, you have the risk of complication of gastric perforation if the delay in gastric emptying is severe, and you have significant dilation of the proximal stomach. Therefore, with the balloon, I think it's important to think about the physiology before you embark on the procedure, in order to minimize the early removal of the balloon and to minimize the intolerance of the balloon. So we do gastric breath testing in order to pick those patients who already have delay in gastric emptying at baseline, or they're on the end of the spectrum where they're more delayed than the average, in order to counsel them to get something different than a balloon, because we don't want this intolerance phenomena. And we did actually a prospective study to show that if you did a breath test in that cohort, you could minimize the intolerance and the early retrieval. Now, for efficacy and picking the right procedure for the right patient, it's a whole different story. And now we're going to have more tools, including genetic testing, including physiological testing, in order to match the right procedure for the right patients, because the driver of obesity is different in different individuals. And that is going to be a topic for the future that is exciting. The data is evolving. I don't think we're there yet, but we're moving toward that direction for sure.
Okay, thank you so much. Jan, what's your thought about the EndoZip device? What's your personal experience about it?
Well, as I said, EndoZip is very nice device, very simple to use and very fast. That's amazing, because if you do overstage endomina, it will take an hour and 20 minutes. If you're experienced with EndoZip, you can be done in 30 minutes. So that's very nice. The question is that you generally do the suture blindly. You can't see what it's really happening in there. So if patient has some adhesions there might be some problems. I can imagine, and you do not have any control on that. So this is for me quite question mark what we should do. And second thing is that there's a lot of waste, because you use 5 dose devices, but they are working on changing devices a little bit better than the whole device. But in general, very easy to use and very fast. So yeah, I like it.
Okay, just to add something, I think the good thing is that there are a lot of work being done for all those devices, working in the stomach and being able to do some sutures in the stomach, which is a good thing because the population is growing. The other thing is that people need to have a proper training in order to do so. You need to, because those procedures are quite, well, it seems easy. As you said, it seems easy to do, just push the button and it's done. So people need to bear in mind that as a gastroenterologist working in endoscopy, you need to be able to manage your complications. And this is, I think, a crucial point, is the fact that maybe you will be able to do something which looks very simple, but when you have a bleeding or perforation, you need to be aware of it and you need to have the tools and know how to manage your complication. So I think this is why there is a bariatric curriculum, and I think people should apply for this curricula to build a strong network and being able to treat properly our patients. What do you think about it?
I think you're absolutely right. The position statement from ESG, I mean, curriculum is very well written, and I think everyone who wants to start doing bariatric endoscopy procedure should go there. And what I can agree even more is it's not just about the procedure, but how you can handle the complications of your procedures as well.
Okay, so Barham, I have a last question for you, and then I think we can finish the webinar. There is a question regarding the endobarrier stuff. Do you know if it will come back on the market, and if we will have the FDA approval this time?
Yeah. So on the endobarrier or bypass liners technology, there's ongoing work. I think it's the technology is works. The question is, how do we do it safely? So I think the endobarrier itself is undergoing a trial in the US, which is part 2, in order to kind of minimize the adverse events profile that was shown in the first iteration of the trial. But other companies are developing endobarrier technologies that is based on different anchoring platforms. So that's another development in that field. And as you could see, that there's also this combination of a balloon and a liner type of technology also coming abroad. So stay tuned. There's the story is not out yet on liners. I think they're going to make it back in some form or shape, hopefully in the near future.
And I think it's a beautiful conclusion for this webinar, is the fact that obesity is a chronic disease. A lot of tools are on the market already, and a lot of tools are more to come. So I think we should stay tuned. And this is really an innovative field with a lot of new stuff that are coming. So guys, thank you so much for being with us this evening. I hope I will see you in the near future, and keep going. So just to remind you, please do not hesitate to become an ESGE member. By doing so, you can apply for a research grant. It's open to application with deadline by the end of October. On top of that, there is the next Congress, which will be held in Barcelona. It's a beautiful city, and the Congress is even better because you have a concentration of all the endoscopists worldwide giving beautiful presentation. So on top of that, the ESG Academy will be launched, or is already launched, I think, and you can click on esg.com and learn a lot of new stuff with exciting news, and then you can also apply for the young endoscopist and become part of the young endoscopist within the ESG. So I would like to end this webinar here by thanks all the participants, as well as my co-workers David and Gabby for this webinar, as well as the ESGE governing board. And please keep posted. The next webinar will be for the best papers in 2 weeks. Thank you so much, and good evening all, and see you soon.